Very good evening, all of you. I'm Sunil Garg. I'm the Secretary for the British Indian Orthopedic Society, and I'm extremely grateful to Rajesh, Karthik, and Sanjay for joining us this evening and present this absolutely fantastic topic of how the current sort of evidence has changed their practice. And without
Sunil, you are muted.
Sorry. Thank you. I'll start again. So, ladies and gentlemen, I'm Sunil Garg. I'm the current orthopedic sort of secretary for the British Indian Orthopedic Society. And I'm very, very grateful to Rajesh, who has put up this webinar together with the help of our fantastic faculty, Karthik and Sanjay. And they will be discussing this absolutely amazing topic, which is how the current evidence has changed their practice. And I think this is extremely relevant. And without further ado, I shall pass the proceedings over to Rajesh. And once again, thank you, Rajesh, Karthik, and Sanjay.
That's great. Thanks, Sunil, and welcome all of you to this BIOS webinar. I'm Rajesh Nanda. I work as a upper limb consultant in the north of England in the University Hospital of North Tees. And we decided to run this webinar on how upper limb practice has changed following the recent clinical trials and evidence that has come out. And I invited my colleagues, Karthik Karupaya, who trained with me a few years ago and now is a consultant at King's College in London, and Sanjay Miranda, who works with me as an upper limb surgeon, who's got a whole host of experience in hand and wrist surgery, as well as peripheral nerve injuries. I'm grateful to my colleagues to have agreed to be part of this webinar. We're going to run our talks one after the other, and then we'll have questions at the end. There's a Q&A section where you can type in your questions or in the chat box. So before I start my actual talk, I just wanted to share something with you. In the BMJ of 2020, there was a study about how to treat proximal humerus fractures. And I don't know how many of you have read this study, this paper on the BMJ Christmas edition. But what they did was they asked 10 experts, 5 from United States and 5 from Germany, and they showed them 9 different proximal humerus fractures and asked them how they would treat these fractures. And what do you think, if they want to operate on these fractures, what surgical option they would choose, and what would they expect the net result of this treatment would be. And they also compared that with macaques, and this was in Germany, and they got 5 macaques to answer the same questions. And these were the questions: which treatment regimen would you recommend? Which procedure would you recommend? And what do you think the outcome would be based on the constant score? And they put these. And this is how the macaques chose their answers. So it wasn't a blinded study, but everyone could know what they were saying. And they analyzed these results. And lo and behold, it proved what most of us usually know, isn't it? It shows that there was literally no agreement between what surgical process would you do, would you operate or not operate, or if you want to operate, what method of operation would you do? So none of the experts agreed with each other, and neither did the macaques agree with themselves or between the experts. So there was poor inter-rater agreement, and all the experts performed similarly, and they all predicted the outcome incorrectly, but the macaques actually predicted it slightly better than the experts. And that's what it comes to us. Are we only looking at expert advice, or are we looking at evidence when we are making our decision? And that is what this webinar is all about, is how we manage our practice in the light of recent evidence. And I will go first and talk about how I manage proximal humerus fractures. So we all know there is a double increase of humeral fractures, one in the younger age group where mostly male hyperactive, or in the older age group, which we are seeing more and more commonly now, and usually females. Way back, Sir Robert Jones had suggested that we should just manage them in a sling, and when they get stiff, just manipulate them. But we've changed over the time, and we have changed because of Charles Neal, who we consider as the father of shoulder surgery. And he came up with this Neal's classification way back in 1970, nearly 50 years ago. And he suggested that more than 85% of proximal humerus fractures are actually minimally displaced or undisplaced. It's only these 15% of the fractures that we are dealing with as surgeons. And he suggested for the elderly age group, for the 3 and 4 part fractures, he managed them with close treatment, with open reduction, or with hemiarthroplasty. And he said that people with close treatment do badly, and hemiarthroplasty gives great results. So is that it? Is that how we should treat all our fractures? Are we sold onto it? And obviously the answer is no, otherwise my talk would have ended there. And it's no, because Neal's classification is not very reproducible. There's not very good inter-rater agreeability there. Neal did not measure the outcome of non-operative with any specific scoring system. The fixation methods that were available to Neal are outdated. We have very more modern techniques now. And I can assure you, Neal was technically a very good surgeon, because the results of his hemiarthroplasties were not replicated by his colleagues in that era, and possibly a lot of us in this era. And he never had the reverse shoulder, which is what we seem to be using a lot more. So I'm going to answer these 4 questions with some evidence. So Hertel's Lego classification has a bit more inter-rater reliability and a better prognostic value. And we all are using more and more CT scans, whether we use a CT-based classification or not, but we do tend to do a lot more CT scans for these patients. And I like Hertel's classification because it is a good predictor of avascular necrosis and helps me make my mind up if I want to fix or replace a particular proximal humerus fracture. And that there is a CT classification, like I said, not commonly used, but we do use CT more commonly. So Neal did not measure the non-operative group very well. And we do treat them a lot, and they heal well, but a lot of them don't have very good outcomes, and it's not very predictable who does well, who doesn't do well. You know, this patient, I would expect it to do worse than the previous one, but ended up doing much better. So there have been studies over the years where they have said that the earlier you start your physiotherapy regime, the better the results with your scoring system, and an emphasis on the post-op rehab, not just putting them in a sling and then manipulating them later. So there were lots of different papers which have come up, which have compared what is the functional outcome following non-operative treatment with getting good results. Even in translated fractures, a lot of work done in Edinburgh with Charles Court Brown and Margaret McQueen's group. And they have found that they do tend to do satisfactory if you manage them conservatively. Surprisingly, the older the patient, they thought they didn't get as good results. Even in varus fractures, their group came up with evidence that they weren't bad, and the result was not really dependent on the varus angulation as much as the age of the patient. So the older the patient, they tend to not do as well as the youngish patient with a varus displacement. Valgus displacement, on the whole, did much better than most other fractures, and they healed very well, and they gave excellent results non-operatively treated. So a lot of papers have come over the years, and generally there's a very variable outcome. There's a lot of talk about function is not as good, even though they get very good pain relief after conservative management. But we have new modern fixation techniques, and we've been fixing proximal humerus fractures for a long, long time, different ways of treating them, whether it's a valgus impacted fracture, which we can raise with these modern locking plates and fix them, or even if when the medial hinge is lost, we can use these plates to lift up the anatomical head and fix them with the Calcar screws supporting the medial hinge. And in the UK, I think we have a 20-year experience of how to manage proximal humerus fractures with locking plates. And with this experience comes a high complication rate, higher than what you would expect from other surgeries, which involves open reduction and fixation. And there's lots of evidence there that this is fraught with risks and complications. Screw penetration, avascular necrosis, poorly fixed, non-unions, infection. These, I'm sure all of us have seen these. Systematic reviews over the years have shown a higher rate of reoperation for fixation of proximal humerus fractures. This study, again, in 2012, a systematic review of 12 different studies. A year later, another systematic review of many studies which show similar outcomes. People started comparing non-operative of fixation with treatment of proximal humerus fractures with a locking plate, and found that the net result after a couple of years is very similar. There was not much difference in the constant scores, at least not, but there was a higher rate of operation or reoperations or complications. And then we come to the hemiarthroplasty. We've already discussed that, we have been doing that where we replace a so-called bone which we think is going to be dead or dubious or denuded or in fracture dislocations. Whether we do hemi or whether we do reverses, and certainly the NJR has shown that we tend to be favoring the reverse a lot more than the hemiarthroplasty. So that confuses all of us. It certainly did confuse me as to what is the ideal way of treating these patients. We have had meta-analysis after meta-analysis, all of them stating that there is not enough evidence. And then this paper came out a few years ago in 2015 from a multi-center trial run from James Cook University Hospital by Amarangan and his team. And this was one of the trendsetters of orthopedic trials, as to put it. And they had, it was a pragmatic study, more than 33 centers, nearly 50 surgeons, recruiting up to 250 patients for the study. And they were randomized to either surgery or conservative treatment. And if you look at the two groups, there wasn't much difference between the two groups based on gender, age, whether the tuberosity was involved or not, days after injury, or the smoking status. And even according to the classification, if you put them down to displaced or undisplaced, whether it was 2, 3, or 4 part. And this was a pragmatic study. It was the surgeon who decided whether they wanted to enroll the patient in the study. If the surgeon did not have equipoise and wanted to manage these patients surgically only or conservative only, then those patients were not put into the study. So a real pragmatic study, what we see day in and day out. And between these patients who were recruited, the primary outcome of the Oxford Shoulder score was not clinically significant at 2 years. And then we have the same results at 5 years, again shows no significant difference between the results. Whether you did the subgroup analysis by age, they were very similar. The p-value was less than 0.5. Or if you did the primary outcome based on, going the other way, or you did the primary outcome based on the fracture type, there was no different. I think the only rider was that there weren't many 4-part fractures in the study. The majority of them were 2- and 3-part fractures. So their conclusion was very clear. They said that current surgical practice does not result in a better outcome for majority of adults with displaced proximal humerus fracture, which involved a surgical neck. And they suggested surgery is not cost effective. why were we getting better results with non-operative treatment as time has passed as compared to a long time ago? And I think one of them was our better understanding of rehabilitation. And we studied all these studies which have been comparing operative versus non-operative. They came up with certain guidelines on how to manage post-op rehab, to standardize the rehab for both the conservatively managed as well as the post-op managed. And with good physiotherapy support, we have seen better results with conservatively managed fractures. There has suddenly been an influx of systematic analysis and meta-analysis of proximal humerus fractures this year. And this study by a group where they looked at reverse shoulder arthroplasty, and they suggested that it does get good, improved clinical and functional outcomes. But there was a rider in it. It was the management of carefully selected patients. This Bayesian network analysis, it's a fancy way of some doing systematic review. And they also found that the reverse shoulder arthroplasty tended to give better evaluation and ranking and constant scores as compared to other modalities of fixation or replacement. Helen Handel and her group, who've done a lot of work on the Cochrane review for proximal humerus fractures. They started way back in, I think, 2001, and this is the third or fourth time they have revised their whole Cochrane review. And in 2022, their conclusion was that there is a good evidence that non-surgical treatment is as good as surgical treatment. But it does have a slight increased tendency of subsequent surgery. But they suggested that there is insufficient evidence, especially when you're talking about under 60s, high energy traumas, when we're talking about tuberosity fractures, where the tuberosities are completely pulled off, like only a greater tuberosity fracture, only a lesser tuberosity fracture, and not a surgical neck fracture associated with it, or fracture dislocations. Another systematic review just came out in September this year, and they concluded that a surgical treatment with either locking plates or hemiarthroplasty do slightly or equal to non-operative treatments, but higher reoperation rates, which have been shown with other studies and from other individual studies. 3 and 4 part fractures, the reverse polarity shoulder replacement results they found was slightly better as compared to hemiarthroplasty. So what do we do as surgeons? And the evidence is there that most of these fractures, whether they're undisplaced, minimally displaced, or those that involve the surgical neck of fractures, we should manage conservatively, especially in the elderly patients. Then there are these fractures, the fracture dislocations. Based on the evidence available, I will fix them, and most surgeons would do the same. And I look at fixation with the background of Hurtel's classification. What is the probability of the humeral head surviving? Is it if it ticks these 3 boxes where the calcar is less than 8 millimeters, the medial hinge is completely disrupted, and the classification shows where the anatomical head does not have any direct blood supply, then there's a 97% chance of getting avascular necrosis of the humeral head. So you tend to err on the side of replacement in those elderly patients. But we have good fixation techniques and they tend to do well. I used to do a lot of hemiarthroplasties in 2012 when there was an influx of reverse shoulder replacements. And I'm still not sure which one to do, though I do err on the side of reverse polarity shoulder replacement. So to answer that question, I have participated in the PROFA2 study, which is again led by Amarangan from James Cook University Hospital in Middlesbrough, along with a couple of investigators from Oxford. And this is about 3 or 4 part fractures, which are either managed with hemiarthroplasty, reverse polarity shoulder replacement, or conservative. So it is a 2:2:1 ratio of patients. And we needed about 380 patients for the study. And I think we are down to the last 80 patients. And this might provide a more robust evidence as to which type of arthroplasty is better, if it is indeed, for 3 and 4 part fractures in the above 65 age group. What we don't want is to do something like this, and this is from one of the German studies, where most of us would look at that fracture on the extreme left and say that we'll manage this conservatively based on the evidence that we have now. But they decided to nail it. 3 months later, the nail failed, and this patient underwent a reverse polarity shoulder replacement. We need to avoid this with the current evidence that we have. We don't want to be experts. We need to provide evidence-based practice. Thank you. So now I'll invite my colleague, Karthik Krupaya, to give his talk.
Thank you, Rajesh.
Thanks, Rajesh. Excellent talk. Let me share my screen.
Yep, we can see it.
You can see it.
Yes, thank you.
Cheers. Good evening, ladies and gentlemen. Thanks, Rajesh, for putting this program together. These webinars remind me of COVID, the webinars which happened during COVID. So I'm Karthik, one of the upper limb surgeons based in London. I don't have any disclosures that will be a conflict of interest with this presentation. The first slide is about the elephant in the room. So if you look at any distal radius fractures, there's a lot of evidence, especially in the last 10 years, which has been produced in UK with regards to managing it. So the first one was published in 2014 by Matt Costa. It's an excellent study where they looked at the distal radius fracture, which is a dorsally displaced distal radius fracture, which is fixed with either KOS or locking plate. And then they found there is no difference in the functional outcome between these two groups. However, if you look at the study in detail, oops, let me see. Yeah. If you look at the study in detail, almost 96% of the patients who's been assessed has been excluded. And there were 244 surgeons who recruited patients over a period of 18 months, and they could recruit 1 or 2 distal radius fractures for the study. So probably the patients, what they selected could be a little bit of a very, not a common type of distal radius fracture, so which might be the reason why in 18 months they could select 1 or 2 patients. Again, if you look at the subgroup, a lot of them are elderly patients. Less than 2% have high energy injuries. It's a pragmatic trial, so I think around 60% of the patients were fixed with junior doctors. This study doesn't apply to my practice. I will explain in detail why, because I work in an MTC where I see a lot of high energy injury patients with distal radius fracture. So the second trial, which is the draft trial, which happened, which was published recently, again showed that there is no difference between KOS and plaster cast in dorsally displaced fractures. So again, I looked at this paper in detail in the BMJ, where if you could look at the picture, if you treat a distal radius fracture with a wire into the radiocarpal joint, obviously the results between a cast and a KOI fixation isn't going to be much different. Having said that, again, it's more in elderly patients with osteoporotic fractures. I work in a MTC, so I see 3 groups of patients. The first group is a complex distal radius fracture, where the patients have associated pelvic fractures. So what happens is the local DGS, they fix the wrist and then send the patient for pelvic injury. So the X-ray, which is shown there, shows the screws penetrating into the joint, but the patient had pelvic injury. So when we screen that the wrist is badly fixed, we end up revising it. The second group of patients is operated by lower limb surgeons without recognizing the complexity of the injury. So this is done by one of the limb recon surgeon. So they have completely missed the ulnar styloid, used the radial styloid plate on the ulnar side, and also missed the lunate fossa, which led to the screw penetration into the joint. The third group, it's a complex wrist injury, which I deal with. So this is a patient which came in my on-call last Wednesday, where we end up putting a fibula plate for the complex ulnar fractures. So the draft trial doesn't apply a lot into my practice. So I'm just going to concentrate on a couple of things, which I see day in and day out, where a lot of us struggle to treat these fractures and end up getting revised or end up patients having a poor functional outcome. The first one is the volar lunate fragment fracture. This is something which has been described in 2004. If you look at the authors, it's Jesse Jupiter, Abe, Fernandez, all three of them wrote this article in 2004. And whatever they have suggested at the time applies even today, because still I see a lot of patients with the failed fixation with the volar ulnar lunate corner fracture. So the most important thing in this fracture is to first recognize that there is a fragment, which is volar and ulnar, the small piece of bone which is broken. So if you have recognized it, then you have to make sure that you have the right implants to fix it, because the entire stability of your radiocarpal joint and the distal radial you look at it, looks like a volar button. You just go ahead and then put a plate. It looks okay, but you're not very happy with it. Then you think in 6 weeks' time, it should stay absolutely fine. 3 months down the line, the joint dislocates. This is classical in patients who have this type of fracture where you didn't recognize it to start with. So I'm just going to explain why there is a high failure rate based on a few papers and what are the tips and tricks in management of this fracture. So if you look at the anatomy of this fragment, it's very small. It's extremely important to the stability of the wrist and the distal radioulnar joint. A lot of load passes through this, and this bone doesn't fit into that area of distal radius. I will explain in detail later. So if you look at the size of the fragment, it's like the size of the peanut, but it constitutes around 16% of the articular surface of the distal radius. It's extremely important for stability of both radiocarpal and radioulnar joint. And if you look at this clinical picture, you could see that it forms the cup part of the ball and cup joint of the distal radioulnar joint and the radiocarpal joint. So if there is any damage to the bone, it leads to instability in both these joints. Again, it's been proven in cadaveric studies from Wrightington. It's extremely important to reconstruct this. There are a couple of ligaments. One is the radiolunate ligament. It's extremely important to provide the radiolunate stability, radiocarpal stability. And the second one is the radioulnar ligament, which is part of the TFCC. Again, it's extremely important in providing the DRUJ instability. This is a very good paper, which has been published in 2021, where they looked at the orientation of the fibers. The radioulnar ligament has a tensile force. So a lot of time we think that this fragment is going to displace volarwards and proximally. But actually the tensile strength is more in the distal radioulnar joint. So what happens is when it fails, the fragment goes ulnarwards and the carpus dislocates. So again, if you look at the amount of weight that goes through this fragment, irrespective of the wrist position, it's around 1 megapascal. It's a lot of weight that goes through this fragment. So that's why if you don't fix it stably, the joint is going to dislocate. This is a very interesting picture. So as this fragment doesn't fit into the anatomy of the distal radius because of the projection both in the radioulnar and the proximal distal direction, it's very difficult to use your normal plate to hold this fragment. So majority of the reasons why these fractures fail is because of improper planning, not having the right implant. And a lot of time intraoperatively, it looks like it's reduced well, but it displays is usually in 2 to 4 weeks time. So if you look at the evolution of distal radius plate, the first ones, it sticks in the distal, near the watershed line because of a lot of complications with regards to the flexor tendons. A lot of the newer plates are designed to sit in the pronator quadratus fossa, and they are curved in the direction so that they can sit and then hold all the fragments all around the distal radius. However, this fragment doesn't come into the pronator quadratus fossa, so that's why it's very difficult if you use a normal plate to hold this fragment down. If you try to use this plate, it's easy to miss. You can break this fragment into pieces and it's very difficult to put it back in. You can also put the screw into the radio-ulnar or the radiocarpal joint. So if you want to approach this fracture, if you are using your Wohler-Henry approach, it's very difficult to put a wire to hold it in place. Unless you go between the FCU flexor tendon interval, it's almost impossible for you to do it from the radial side, unless you go between the FCU and the flexor tendon interval. So this is a little bit more extensive. This is a tip which has been published in Journal of Hand Surgery, where they have used an extended carpal tunnel type of approach. So I don't go all the way into the palm. I use this approach, but I stop it just near the distal palmar crease because your ulnar lunate fragment is situated just proximal to the proximal wrist crease. So you don't need to go all the way down to get the wire into this fragment. So I'm just going to run through a few tips and tricks, and then we will move on to the next topic. So there are various ways to fix this fragment. You can use a screw or a wire or a different plate. I tend to use a hook plate in simple fractures, and then a rim plate with where there is a comminuted fracture along with ulnar lunate fragment fracture. It's also better to have a K-wire guide and a dental hook to reduce this fracture. The K-wire guide will prevent the wire from damaging your flexor tendons and the median nerve. So let's go with a simple fracture. So this is more like a dorsal radiocarpal fracture dislocation, where if you look at it, this is post-reduction, looks okay-ish, but this fragment is really, really small. And if it don't recognize this, this is going to be a disaster. So you can look at the CT now. The CT shows the size of the fragment. So this is the radial side. And then when you come back to the ulnar side, it's a quite small fragment there. And you can see it's moved a little bit on the ulnar side. So in these fractures, tend to put a wire first in the to get the length in the radial styloid, the dorsal wire to correct the volar angulation. And once that's done, you can use a hook to reduce this fracture and fire a wire from the ulnar to the radial direction to hold the fracture in place. So once that's done and you are happy with the alignment, then it's a straightforward plate to fix it. Always do assessment of these fractures with fluoroscopy just to make sure that the joint is stable. If it's stable, then you can get these patients moving straight away after you have fixed this. So this is a delayed presentation where this was treated by one of my foot and ankle colleagues. So he had the patient as a 45-year-old gentleman had a accident while he was riding a bike and had bilateral wrist fracture. So this is the one on the left side. This is the one which is a minimally displaced one. This is a completely dislocated one. So the one where there's a complete dislocation, you could see that he tried to fix it with a regular plate, and the regular plate doesn't want to sit there. It's because it's not designed to hold this fragment. So After multiple attempts at wire and stuff, he managed to put a plate, but you can see this fragment hasn't been fixed. But the alignment looks reasonably okay. Even on the other side, it looked okay. Again, 4 to 5 weeks down the line, completely dislocated on this side. And on this side, you can see the lunate has subluxed along with this fragment. And this chap works as a chef, where his hands are extremely important. So this is the side where he has a fixation, the other side where it was treated conservatively. So it's pretty much the same approach. You go till the distal palmar crease, find, if possible, it's better to find the palmar cutaneous branch. So that's the radial side, and you can see the ulnar side. Exactly same process, put a hook plate, compress it. Usually it reduces reasonably well, even if it's 4 or 5 weeks down the line. And then get them moving. The most important thing in this fracture is it's better to put a couple of sutures to hold the radiocarpal and radioulnar ligament, because if you don't repair it, that's if the fragment is too small, there is always this risk of displacement, especially if you want to ask the patient to move straight away. This is the side where he had the plate, remove the plate. Sometimes it's difficult to fix the fracture because of callus, so you have to clear the fragment. You might need to put a point reduction clamp to reduce it and put the plate on. Repair the ligaments, get them going. As this plate sits really on the ulnar side, make sure you could see the DRUJ at the end of the procedure. So this is him.
Tell me, how did you do
4
this?
months down the line, actually.
Crashed on 50 miles an hour on a motorbike by hitting the back of an ambulance.
Okay. How do you feel? How is your wrist now?
Perfect. No discomfort, no nothing. Especially after I'm working as a head chef.
Okay.
I don't have any problems with lifting anything, cutting knives or anything. Working out at the gym and lifting 100 kilos, no problem.
The most important learning point is, even if this is a delayed presentation, you can give good functional outcome if you could get a good anatomical reduction, motivated patient, good physiotherapy. Usually patients do really well, irrespective of how bad the injury is. So the last one is a difficult fracture where it's a 35-year-old gentleman. He's a prison guard, bilateral injury. One side, it's a mangled hand. So all the tendons are cut. The other side, again, quite a nasty injury. You could see a part of the volar lunate fragment is flipped 180 degrees. This is difficult because there's no support between the radioulnar joint. So in those cases, I do both dorsum and volar. And when I do the dorsum, what I do is I try to repair the ligaments around this to the plate. And in the volar, it's a classical rim plate. And once you get the stable fixation, the most important bit in these patients is to get them going. If you don't get them going, they're going to end up with a very stiff wrist. So this is him a few months down the line. He's doing reasonably well. He has got like 80–90% of the function back in his wrist, because the other hand, he has literally no function. He's just using it for support them. Salvage options. So if the patient presents a few years down the line after everything has been missed, where it's articulating with the distal radius plate. So this is the patient where initially, if you look at the x-rays, it's very well reduced, but over a period of time, it subluxed, which was missed, and then ended up with arthritis. So I looked at the intra-op image. I could see this volar ulnar corner, which the surgeon tried to fix it multiple times, putting hundreds of wires, and even one of the wires was broken. He has to take it out. So that's the reason you could see the screws penetrate into the joint. When I put the scope in, it's like a grade 4 arthritis. So ended up doing a radiocarpal fusion, radioscapholunate fusion. Usually that gives decent function, but they always will be having some bit of pain. So when there is a volar ulnar corner fracture, Don't worry to get a CT scan, intra-articular distal radius. It's better to get a CT if you're worried. And if there is a fragment, you need to fix it. If you don't fix it, it's going to sublux. And there's plenty of evidence to support it. And as I have told you, you need to use the right approach, right implants, and then start moving them earlier. Just going to quickly go through this distal radius, failed distal radius fracture fixation. So if you look at the failed distal radius fracture, there are a lot of late complications which has been shown in the literature, but none of them shows anything, acute complications where you need to do. So being in a MTC, what is my experience with acute fracture where you need to do something is you have to use your common sense. There is a common thought that you can't debugger surgery or do no more harm. However, if you see any of the following scenarios, it's better to do something or send the patient to the right people. So this is an 84-year-old lady, had a distal radius fracture, manipulated, okay-ish wrist. Someone tried to put a plate, they didn't fix it. They want to fix it, but they didn't fix it. And this is how it ended up: 6 weeks. 3 months, and she has decent movements. Everyone left her as such. She came back 3.5 months down the line with a FPL rupture, 6 months down the line with a FDP rupture, and she literally has like 3 kg of grip strength on the affected side. So we ended up, and then also had injury to all the FDP of other fingers, like middle ring and the little finger, in addition to the FDP, complete rupture of the index finger. So in these patients, it's better to take the plate out if you think of any soft tissue compromise. Better not to fix it. If you fix it, if you're worried about soft tissues, it's better to take the plates out as soon as you could. Second is a manual labor, again, a road traffic accident, complex wrist fracture, treated by one of the limb recon surgeon. Did a decent job looking at it, except for the plate is being in the DRUJ. And this is him at 2 weeks, and at 6 weeks, you can see that it's getting into the DRUJ. This plate is only holding the scaphoid fossa, the lunate fossa is coming out, and everything is hanging around in this patient. So when there is if you don't support your lunate fossa, the fracture is going to collapse and the patient is going to end up with a poor functional outcome. So lunate fossa, if not supported, it's better to go back and put a wide plate and then get these patients moving as soon as possible. So this is a few months down the line, got good function. The third group, again, this is the one which I mentioned to you. So the patient had a pelvic fracture. The local hospital tried to fix the wrist, screws in the joint. Always put a scope, document whatever is there, and then use your scope to try to reduce the articular surface, fix it. Usually they get decent function back. If you leave it as such, that's going to end up with a radioscapholonate fusion. Again, this wrist spanning plate, there's a lot of people using wrist spanning plate, different ones. So whenever you use it, you have to reduce your radius. If you don't reduce the radiocarpal joint, the wrist spanning plate is not going to do any magic to get the function back. So this chap ended up with revision surgery, fixation, got decent function back. Again, you have to look at this is again a complex injury with volar lunate fragment fracture, treated with the X-fix and a plate in Germany, 6 weeks down for the follow-up. She came to us and she had a DRUJ dislocation because she couldn't rotate the wrist. So we ended up taking that out, repair the TFCC. This is when she came for removal of wrist plate. So if you find any DRUJ dislocation, you have to reduce it and then repair your TFCC. Otherwise, they're going to end up with a very poor functional outcome. This is something, the last case, where you shouldn't do, but this was done in one of the hospitals in London where this was an open fracture. So they took him to the theater, in a 78-year-old chap, put a wire, all the wires were at the fracture site. Few weeks down the line, everything fallen apart. took him back to the theaters, and then put a X-fix. You could see that there is now a segmental fracture in the radius, in addition to mal-reduced radiocarpal joint and a lot of distraction. So the patient was referred to us with a lot of carpal tunnel symptoms, in addition to the wound, which was oozing a little bit. So we ended up revising, putting plates and screws so that we can get him moving straight away. This is him asking not to fix his wrist in future if he breaks it. So whenever you see any radius fracture which is poorly fixed, where the lunate fossa is not held by a plates or screws, especially in unstable injuries, and if there is any DRUJ dislocation, then it's better to revise it straight away. They do reasonably well. There isn't a lot of evidence. Thank you.
Thanks, Karthik. That's absolutely wonderful. And it's a wonder how a lot of these different distal radius fracture patients survive from surgeries, when there's a lot of lack of understanding on how to manage these complex injuries. And it's not as simple as just putting them in plasters or just wiring them. But thank you very much for that. I'll invite Sanjay Miranda, as a colleague of mine, a hand and wrist surgeon at University Hospital of North Tees. Sanjay, if you could share your screen, and he's going to talk about his practice of scaphoid fractures. Thanks, Sanjay.
Thank you very much, Rajesh. That's great. Thanks. I've been educated by both of your talks, Rajesh and Karthik. Good evening, everybody. I'll just get this into mode. Is that running okay?
Yes, it is.
Yeah, okay. So Rajesh gave me this talk to have a chat, and it's always interesting to talk about recent evidence. It's actually potentially quite a big talk, so I've picked out a few things that might be of particular interest. So I specialize in hand and wrist and peripheral nerve. I worked for about 14 years in a major trauma center, and then now I've joined Rajesh and a few other upper limb surgeons to predominantly do hand trauma. So scaphoid fractures is a big part of my work, really. So why are scaphoid fractures important? It's the most commonly fractured carpal bone. 60 to 70% of all carpal fractures, 11% of hand fractures, and 2% of all fractures. The incidence, as you can see, 29 to 43 per 100,000 people. And most commonly it is young males, 15 to 25 age range. We all know, commonly said, it's a fall on the outstretched hand that causes this problem, but there are some peculiar mechanisms, of course, football injury, hyperextension injury, people weight training and falling over, bicycles, hoverboards, all kinds of stuff. So yeah, FUSH is the common one, but also think about other sort of mechanisms of injury. We often get referred this as an acute fracture, and I'm sure many of you looking at this X-ray will say, I'm not so sure about that being an acute fracture, and you'll be right. This was a referral a couple of weeks ago. So those who are not expert at looking at this don't necessarily pick up what to some of us that might be very obvious signs, like a cystic change here. And the patient really did not say that they'd had an injury. They weren't even aware. They were told they had arthritis of the thumb. And when we look back at the old x-rays, the fracture's been there for a few years. So these aren't always acute fractures as well. So bearing that in mind in our presentations in clinic. Scaphoid fracture is also quoted to have a high non-union rate and ranging between 5 to 50%. Overall, it's about 10 or 12%. And this non-union relates to several factors, including a delayed or misdiagnosis, as in this patient here, inadequate immobilization, because either maybe the patient doesn't present early enough, or that urgent care or emergency department feel that simply a splint will be sufficient when they suspect a scaphoid fracture. Fracture displacement, of course, and we all know about the blood supply of the scaphoid, which is retrograde from branches from the radial artery, entering the distal part of the scaphoid and via intraosseous circulation to the proximal pole. So the more proximal the fracture is within the scaphoid, the higher the chance of non-union. So that 50% is more likely in the more proximal injuries. So what's actually not changed in our management of scaphoid fractures is, number one, is a high index of suspicion, because many of these fractures will be missed are not diagnosed, and the patient may even pass it off as a wrist sprain, and carry on with their activities, especially the sporting population, the military population that we see. So a high index of suspicion. So the consequences of missing this fracture are high morbidity, both economic, because people can't work, especially in the current cost of living crisis we have, and also physical morbidity. A scaphoid non-union is guaranteed to cause degenerative changes within the radiocarpal joint within 5 to 12 years. This is a known fact and proven time and time again. Also, the consequences of overdiagnosing a fracture, where you think there is a fracture and there isn't, as I will talk about in the next slide. So why are scaphoid fractures diagnosis delayed? Well, X-rays could be up to a 35% false negative, because often they're simply a PA or AP view and lateral view of the wrist, and this can actually hide the fracture. So you have to request a scaphoid view. Now, there is a scaphoid view and a scaphoid series. Scaphoid view is a PA view with the wrist in ulnar deviation, so the wrist that way, and that elongates the scaphoid and gives you the best shot of the scaphoid. In most departments, there is a semi-pronated and a semi-supinated view to look at both the proximal and distal part of the scaphoid, and of course the lateral view. For those of you who know how to measure a scapholunate angle, on the lateral view, one of the clues is that the scapholunate angle should be between 30 to 60 degrees. If that is increased, worry there is certainly an injury, could be a ligamentous injury, or even a not so obvious scaphoid fracture. So if you get presented with AP lateral views, you do a virtual clinic, look at the lateral view and look at the scapholunate angle. And if you think that is greater than 60 degrees or less than 30 degrees, then there is some form of a major injury to that wrist, either ligamentous, could be acute or chronic, or possibly a not very obvious scaphoid fracture. So in a virtual clinic, someone like that, you'd want to bring back for examination and X-rays. Speaking of examination, also, we all know about anatomical snuff box tenderness in this area of the wrist at the base of the thumb. But with the wrist in neutral, the majority of the scaphoid is actually hidden by the scaphoid fossa of the radius. So if you really want to expose the scaphoid, you have to place the hand in ulnar deviation, and then you can palpate the distal 50% to 60 to 2/3 of the scaphoid. So anatomical snuff box has to be done with some ulnar deviation. In neutral, majority of the scaphoid is only this very distal part of the scaphoid that is palpable. Second examination is axial compression of the thumb. So you place the thumb with forces in that direction, and the patient will report pain within the anatomical snuff box. So these are two good tests to add to your armamentarium. So what's not changed is to have a high index of suspicion for scaphoid injury. So what has recent literature informed us to make some changes in my practice? So traditionally, if there is a suspected scaphoid fracture, the patient is immobilized in a cast, we see them back at 10 to 14 days, take another X-ray. Fine, it works because the fracture will be more visible. However, what about the morbidity of being off work for 2 weeks? For some people, that can mean the difference about staying where they currently live or not, or getting a loan or whatever. So, and think about it for yourself. If you had a fall, you have a scaphoid, have a cast on, suspected scaphoid fracture, think of the impact it would have on you for 2 weeks not being able to work, perhaps not even drive as well. It's a massive impact. Whereas if a diagnosis was made early and you rule out a fracture, and perhaps it's although painful, it's not a serious injury, you could get on and do something in your job. So think of it from that point of view. 2 weeks is a long, long time and very, very serious potentially. So early MRI. possibly from emergency department, minor injuries unit, or urgent care. This was a service evaluation looking at 337. A couple of the authors on here are part of the suspect group. This is a study group looking at suspected scaphoid fractures, and they're doing a lot of papers coming out from their group. So 337 patients from a single center prospectively with early MRI. And what did this show? Well, about 30% have 40% have some form of injury, 13% scaphoid fracture, 6% scaphoid contusion or bone bruise, and 22% fracture of another bone, such as the distal radius, for example, or capitate. 30% are the contusion or ligament injury, 10% purely degenerative. So this is a 30% group, non-scaphoid, non-fracture. And 30% no abnormality. Now, if you could get this diagnosis within 2 or 3 days, wouldn't it be much better for this patient? And we can rule them out and also perhaps save a lot of numbers in your clinic, all these query scaphoids, as we call them. The MRI protocol does not need to be so detailed. You can discuss this with your radiologist. And in most departments, this cycle can be done in 8 minutes because you don't need super detailed imaging. You just need to see where the edema is in the bone, like in these two pictures. You see the edema, distal radius, scaphoid, great, you've got your answer. If the x-rays don't show displacement, super, cast them for the scaphoid. Distal radius, you might or might not cast them, splint them, especially non-displaced fracture. So consider this, and I would really urge you. We did this for many years at James Cook Hospital from 2005, and we didn't have a problem with emergency departments, and they loved it because they were taking control of these patients. It helped reduce some of the numbers coming to our fracture clinic as well. Remember, I said these are 2% definite scaphoid fractures. Think about the query scaphoids. Depending on your emergency department, that could be, 1/5 of your clinic. So once you've diagnosed the fracture, so what can we do? Well, cast treatment, as I mentioned, is traditional. But since the 1980s, early fixation advocates, because on the basis of better implants, you can see from here, there is a cannulated screw for every kind of fracture in the hand and wrist. And the advocates of early fixation thought it would be better to fix them for a basis of better outcome and earlier return to function and quality of life. But where was the evidence? There's a lot of case series, poorly powered studies. So this fantastic study, SWIFT, scaphoid waist internal fixation for fracture trial, run by Professor Dyers from Leicester, published in the Lancet in August 2020. It's a pragmatic randomized control study. 439 patients met the criteria and completed it, done over 4 years across 31 UK centres. CT scan done pre-randomization to confirm the fracture and ensure it was not displaced, and it was a waist fracture because that was the criteria, and this was in adults. And the CT scan was used to confirm union at 6, 12, and 52 weeks. So what was the result of this? Was it better to fix them because the study was randomized into 2 arms, one arm for early scaphoid fixation, either open or percutaneous, whichever implants were used by the consultant surgeon. So this infographic shows, so there's 219 patients on the fixation group and 220 on the cast group. Statistically, there was no differences between the demographics of the patient. What was the benefit? Well, fixation group, 16 days off work. Cast group, 18 days off work. Not significant. Pain and function by the wrist score, 12 and 14 at 1 year. Very little difference, not significant. Sorry. Healing, 98% and 96%. So not significant at again, 12 months. Risks, however, fixation, moderate complications, including malposition, nerve injury, infection, 12% as opposed to cast 2%. And the cost you can see here, significant, over 3 times more expensive to fix as opposed to cast treatment. So the study concluded really that cast treatment was suitable for non-displaced waist fractures, which is the majority, with a good result of 90% plus union rates. Even proximal poles were, sorry, junction of proximal pole and mid-third also had these results. So it really justifies doing cast treatment. So this is, even during the study, they found that the participants were changing their behavior of how they were treating, because interim results were being released through the study. Then they found the actual fixation rate of cases that were not in the study was actually decreasing as well. So this is a cannulated screw. Since Tim Herbert first published his technique and marketed the implant back in the early 80s, cannulated screws then appeared variety kinds. And however, in failed non-union surgery, where there is large cyst within the scaphoid, a revision screw may not be possible for stronger fixation. So another option, which I saw some years ago, but thought, this is a gimmick and really not very good. It's actually volar plating. This was actually first described in 1977, albeit not with this implant. This is actually a locking plate. And if you've got a large defect, it's not stable to be fixed with a screw, this implant can be used. This is a meta-analysis looking at quite a lot of papers actually. So I draw your attention. So this first column is screw fixation, cannulated screw, and the second column is plate fixation. Time to union. Plate fixation, they're compared to cannulated screws, certainly not as good. The modified Mayo risk score, not as good, and it was significant. Complication rate, the difference was better with the cannulated screws, again, significant. And reoperation rate was also significantly different between the plating. So you're saying the plating, what's the point of doing it? So the authors concluded that plating was suitable when there was a failure of non-union surgery initially with a screw, and this can be used as a revision of a non-union surgery in the first case. So failed non-union surgery, sorry. So in summary, what has changed? What has not changed is having a high index of suspicion of the injury, good quality examination. What has changed? Consider early MRI in suspected scaphoid fractures, cast treatment for the majority, but monitor and fix the scaphoid fracture if it's non-union at 12 weeks. And also you have another tool in your armamentarium of the locking volar plate for failed non-union fixation. But of course, this is in specialist hands. Okay, I wind up here and open for questions, I guess. Thank you for your attention.
That's great, Sanjay. Very succinct way of managing scaphoid fractures. And I think thanks to all your guidance, this is the kind of practice we are following in our department now, isn't it? Where they are getting early MRIs and being seen by the hand specialist who do fix them appropriately and properly.
It's just seeing them in time. That's the main thing.
Yes.
That's great. Excellent talk, Sanjay. Just a question, actually. I know Sunil will be able to answer this a little bit. So it's regarding, this Nottingham study where they put the patients in the plaster and then do a CT in 4 weeks' time. And if there is no evidence of trabecular bridging, what Tim Davis and co suggests is to, if it's 2 millimeter gap, you go ahead and fix it, do a CT at 4 weeks, and then decide on the management from there. What are your thoughts on it?
Are you asking me or asking someone?
Yes, yes, sir.
Well, why CT at 4 weeks? Why don't you CT early on? If you're going to CT them early on, make a decision early, because if it's displaced early on, then you're going to fix it. If it's not displaced, then, or it may have been incomplete fracture, because, what you're looking on an X-ray are often shadows. And so CT sometimes pick up incomplete fractures too. So I think, you're going to CT, if that's going to make your decision making, you do it early. Alternatively, what Joe shared from the SWIFT study, there's no need to have a CT until you get to 6 week stage when you have your X-ray. So I'm not sure about the 4 week. Is that just bringing the time scale forward a little bit? Perhaps it's a little bit early.
I think they did a study. So at 4 weeks, if there is any evidence of a trabecular bridging,
Yeah.
they discard the plaster,
Discard the plaster, yeah.
and then
Yeah.
get them moving, kind of stuff. And they've prospectively followed up those patients where which one went for non-union, which one went for complete union, and they have some criteria. So if you do a CT at 4 weeks, and if there is trabecular bridging, you don't need to worry about it, get them moving straight away. But if there is like a 2 millimeter gap, cavity kind of stuff, then the risks of non-union is quite high. Instead of leaving it for 6 weeks or 10 weeks, you just go ahead and then fix it. I think that's what the message from them.
Yeah, I mean, the other thing is do you all have access to get CT that good, that, easily? I don't know whether we don't really. CT is oversubscribed. We just can't get it.
Absolutely.
You're muted, Rajesh.
Shanawaz, do you have to?
Hi, thank you, Rajesh. It was a great talk. All three talks were really good. Quick question to Karthik. You've alluded that a lot of trauma recon surgeons have still not fixed or understood the mechanics of the wrist and the DRUJ. So are you suggesting that now even the distal radius fracture should be specialized in terms of treatment, like how the shoulders and elbows are going?
See, the thing is, actually, it depends on where you are, kind of stuff. If you are based in a DGH practice, where your fractures are simple, straightforward fractures, where you have considerable experience in fixing it, I don't think there is any any issue at all with that. So we see a little bit of a different breed of patients in MTC, where there is a lot more complexity involved. And if you look at the MTC, most of the MTC, how it works is all of us are more or like very specialist practice. So I do purely upper limb, even though I have done revision hips, knees, and all those things. I don't go near it at all in the last 6-7 years. So you get gradually de-skilled over a period of time, and then suddenly, if I want to fix a tibial plateau or a intra-articular hip, then I would say I would hesitate quite a bit.
Yes.
I think that's what the thing is. It's all to do with the complexity and how frequently you are doing rather than anything else.
But also, I think people recognizing.
Yes.
Because there are times when people don't recognize what is serious. I think that is also a key, because most of the surgeons doing these things are, you're experienced in fixing distal radius, but it's not to miss the one. For example, like the radial styloid, where the fracture line goes obliquely and finishes exactly at the scapholunate joint. That is potentially actually part of a greater arc perilunate injury. And people don't pick it up, and also seeing on the lateral view, your scapholunate angle is increased along with your fracture, your distal radial ulnar joint instability. But once you fix the plate, anyone can examine the DRUJ. If you've got a laxity there, okay, you're going to cast them, but you'll get some advice from the hand and wrist surgeon. It's not urgent. So I think those are the kind of things I think about. Not so much you'll fix it wrongly or fix it poorly, but rather you'll miss what might cause ongoing problems down the road.
Absolutely.
Yeah, I agree with Sanjay, because it's recognizing which is important. And even in DGHs, we have 3 hand surgeons and 3 other upper limb surgeons who do offer that service to our colleagues when there is a complex wrist fracture, distal radius fracture. We do take over the care for that. So it is becoming a bit more specialized, possibly more because we are recognizing that there are long-term problems, rather than relying on those earlier papers where they said that just put them in a plaster and they'll be fine, and they still go back to their job and they still don't get arthritis, a 40-year follow-up. But it's more complex, what we are seeing now.
And also people's expectations are a lot higher now. 60-year-olds and 70-year-olds are doing a lot more than people were doing half a century ago. So I think expectations have gone a lot higher too.
Right. Sunil, you have your hand up.
Yeah, thanks. So lots of learning this evening, really. One of the things I wanted to ask Sanjay, really, very good presentation on scaphoid, is about early MRI. And obviously, the most obvious question is how do you get funding for this? And has it really become the standard of care, or is it still a recommended practice from the British sort of Hand Society? What are your thoughts on that?
Well, the NICE guidance talked about this in 2016 about getting MRI specifically in scaphoid fractures. So actually it is a recommended practice, and if people aren't doing it, you're not following recommended practice. Funding wise, well, I mean, you know, you're going to have an MRI at some point. You just decide between yourselves where it's going to go from. And I think the most efficient and cost effective way is for them to go from emergency department and minor injuries unit. The advantage you can tell the MIU guys is, look, you can't see a scaphoid fracture on, slap them in a splint, quick, book an MRI, but you need to have a protocol and a flow chart for it. But it's not difficult. We were doing it in 2005 and talking with the radiologist, we told them, look, what we want to see is where the edema is. That's all we want to know. We don't need anything more complex than that. So it's an 8-minute sequence, and that's all it took in 2005. So they can slip them in between patients. They've got a splint on, they go straight in, go in, and some patients were being sent the same day.
Yeah, I work in a different country, Sanjay, because I had to convince my trust for the last 3 years to get an out-of-hours MRI scan for cora equina. So,
wow.
So convincing them for an MRI scan for a scaphoid fracture is going to be absolutely take me another 5 years, I think. But point well made. I do agree what you're saying.
I think it's a business case, isn't it? You've got to work out the leverage for people, where the things it's going to be, you know, some form of leverage in your own healthcare situation, I guess. You know, if it's a privately funded system, well, there's revenue for the hospital. You're going to bump up the revenue. If it's you know, you work it out, I guess.
No, I'm in a district general hospital, you know, so you know, there's no private work in this hospital. It's completely NHS work. So, but you know, I take your points on board. Thanks for that.
Yeah,
I think Sunil, there's a lot of cost benefit analysis of doing day 1 MRI versus day 14 or day 21 MRI. One of them from UK actually, and it showed like you save around 4,000 pounds or something if it's done. Because what happens is, if you look at 100 patients with the pain in the scaphoid fossa, less than 10% have an injury. So you immobilize unnecessarily 90% of the patients in plaster, and then, you know, 2 weeks, they still have pain, X-ray, not clear, bring them back in 6 weeks, still not clear, X-rays were fine, and then, you know, the patient has stiff wrist, he can't work. So that's what happens to the 90% of the patients. So there's a good cost-benefit analysis work on it.
Yes.
Yeah, no, that's true.
Yeah.
90% don't work in my area anyway.
Yeah.
As Sanjay has told, there's a limited MRI series, so you don't need to go through the entire one. It takes few minutes. Yes.
Okay. I think that's very good. I think there are no other questions on the chat or the Q&A, so we can bring this session to a close. I must thank Sanjay and Karthik, who were very prompt and agreeing to support this session. So thank you very much, and some really great talks and learning. So thank you very much, and thanks Sunil for giving us this opportunity, and Shanavas to helping us run this session. Thank you very much, everyone.
Thank you very much, guys.
And thank you for all the attendees.
Thank you.
Cheers. Thank you.
Thank you, attendees.
Okay.
This talk will be available on the YouTube channel of BIOS, hopefully very soon, if you want to revise it. And I'm sure Sanjay and Karthik and Rajesh don't mind this. Is that okay?
That's good.
Yeah. Thanks so much.
That's great. Thank you.
Yes.
Bye. Good night.
Bye.
Okay. Bye-bye.